Disseminated intravascular coagulation, or DIC, describes a situation in which the process of hemostasis, which is when, after blood vessel wall injury, liquid blood rapidly becomes a gel, called coagulation or clotting, starts to run out of control. When this happens, lots and lots of blood clots start to form in blood vessels serving various organs, leading to organ ischemia. DIC, though, is also called consumption coagulopathy, because all this clotting consumes platelets and clotting factors. Without enough platelets circulating in the blood, other parts of the body start to bleed, with even the slightest damage to the blood vessel walls. So paradoxically, patients have too much and too little clotting. Normally, after a cut and damage to the endothelium, or the inner lining of blood vessel walls, there's an immediate vasoconstriction or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated, and then recruit additional platelets to form a plug. The formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood there's a set of clotting factors, most of which are proteins synthesized by the liver, and usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. This cascade has a huge degree of amplification, and takes only a few minutes from injury to clot formation. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to fibrin reinforcement of the platelet plug make up the process called secondary hemostasis, and results in a hard clot at the site of the injury. Now, as soon as that clot's formed, the body's also initiating pathways to break down the clot, so that it doesn't get bigger than it needs to be, and dissolves when it's not needed anymore, a process called fibrinolysis. And this process produces fibrin degradation products. Normally, the formation of new clots and the process of fibrinolysis are in a steady balance. Now, in serious medical conditions, like for example sepsis, malignancy, serious trauma, obstetric complications, or intravascular hemolysis, like you might see with blood type incompatibility, there can be a release of a procoagulant that tips the scales in favor of clot formation. Procoagulants could be proteins, like tissue factor, or bacterial components, like lipopolysaccharide. Or it could even be the presence of enzymes that help to proteolytically cleave and activate clotting factors. Whatever the cause is, in response, the coagulation pathway goes into overdrive, resulting in widespread clot formation, which plugs up medium and small blood vessels, which leads to ischemia, necrosis, and eventually organ damage. The kidneys, liver, lungs, and brain are particularly susceptible. The massive formation of clots throughout the body depletes the supply of platelets and clotting factors. To make things worse, as those clots are broken down through fibrinolysis, fibrin degradation products are released into the circulation, and these interfere with platelet aggregation and clot formation, making hemostasis even more difficult. And the result is this paradox, right? On one side you have thrombosis, which is when clots obstruct the vessel, and at the same time you have trouble forming new clots, which leads to bleeding. Laboratory findings in disseminated intravascular coagulation include decreased platelets and decreased fibrinogen. There's also a prolonged prothrombin time, or PT, as well as prolonged partial thromboplastin time, or PTT, both of which reflect having lower levels of circulating coagulation factors. In addition to lower levels of specific clotting factors, there are elevated levels of D-dimer, which is a fibrin degradation product that's produced when fibrin clots are broken down. Now, it's worth mentioning that in some cases, disseminated intravascular coagulation can be a more chronic process, like in individuals with certain solid tumors and large aortic aneurysms. And in those situations, there might be physiologic compensation, which makes the lab results look relatively normal. In either acute or chronic DIC, the treatment focuses on treating the underlying cause, because that's what drives the activation of the coagulation cascade. In addition, the goals are to support the various organs using measures like ventilator support, hemodynamic support, and transfusions if they're needed. Alright, as a quick recap, DIC happens when the balance between forming new clots and breaking down clots is tipped in favor of clots, which leads to widespread clotting and organ ischemia, while at the same time depletes clotting factors, paradoxically leading to bleeding.
The term heparin-induced thrombocytopenia can be divided into two parts. Heparin refers to an anticoagulant medication which prevents blood clots from forming, and thrombocytopenia refers to decreased number of thrombocytes or platelets in the blood. So, heparin-induced thrombocytopenia, or HIT, is a complication caused by heparin that results in decreased platelets in the blood. Okay, so imagine you're making dinner and accidentally cut one of your fingers. Now, if your body doesn't stop the bleeding, you'll keep losing blood until there's not enough to supply the vital organs like the heart and brain. Now, to prevent this from happening, the body has a process called hemostasis. This process has two phases: primary and secondary hemostasis. In primary hemostasis, platelets aggregate to form a plug at the site of an injured blood vessel. While these platelets are aggregating, coagulation or secondary hemostasis starts. This is where numerous enzymes that are always floating around in the blood, called clotting factors, get proteolytically activated, meaning that activation happens when a small piece is chopped off, a bit like pulling the pin out of a grenade. These factors activate one another, eventually leading to the activation of fibrin, or factor 1A. That results in a fibrin mesh, which forms around the platelet plug to reinforce it and hold it together. Without primary and secondary hemostasis, our body would suffer massive blood loss from even the most minor injuries. Imagine losing all your blood from something as simple as a pinprick. Okay, so heparin-induced thrombocytopenia is caused by heparin. This medication works by activating an enzyme called antithrombin 3, which inhibits coagulation factors 10A as well as thrombin. This halts secondary hemostasis and prevents existing blood clots from growing larger. So it's often given to people who suffer from pulmonary embolisms, strokes, and myocardial infarctions. Now, the main mechanism behind the development of HIT is actually an immune response, which starts when heparin binds to a protein on the surface of inactivated platelets called platelet factor 4, or PF4. Together, they form a complex called the heparin-PF4 complex. This complex is immunogenic in certain people, meaning they have circulating IgG antibodies that recognize the complex as foreign pathogens. So, these antibodies will bind to the heparin-PF4 complex and mark it for destruction within the spleen. Now, when the antibody binds, it causes the platelet to activate. The activated platelets release procoagulant chemicals like thromboxane A2, or TXA2, which causes other platelets to activate. At the same time, the original platelet will also release more PF4s, so more antibodies will bind and keep it activated. These events lead to more and more platelets getting activated, and they start forming clots throughout the body. This way, a lot of the remaining platelets also get consumed, which results in a low platelet count. It generally takes a week for the body to make IgG antibodies that target the heparin-PF4 complex. Thus, thrombocytopenia typically develops 1 or 2 weeks after starting heparin therapy. The exception is that if heparin is given to someone who was already treated with heparin previously, they would already have the antibodies against the complex, so thrombocytopenia may develop within a day. Now, the widespread formation of abnormal clots can lead to life-threatening thrombotic events, which are most often venous, causing deep vein thrombosis. Sometimes, this thrombus can break down, and part of the thrombus, also known as emboli, can lodge into the pulmonary circulation, leading to pulmonary embolism, which is often life-threatening. Thrombus can also develop in cerebral veins, leading to cerebral venous sinus thrombosis. Compared to the venous thrombosis, arterial thrombosis is less frequent. Arterial thrombosis can block the arteries supplying limbs, causing limb gangrene, or brain, causing stroke, or heart, causing myocardial infarction. Now, the diagnosis of HIT is often made clinically along with the help of some laboratory tests. For example, individuals who recently started heparin therapy and experience a decrease in platelet count either within 1 to 2 weeks or within a day suggests HIT. The level of platelets can be found by using a complete blood count, or CBC. Other diagnostic tests include an ELISA serological assay to detect the IgG antibodies. However, many individuals that have received heparin previously will have these antibodies, but not all of them will develop HIT, so the test is not very specific. A more specific test is the serotonin release assay, which is the gold standard for diagnosing HIT. In the serotonin release assay, the patient's serum is mixed with heparin and donor platelets. Activated platelets release serotonin. So in a positive test, the patient's serum has antibodies that activate the platelets and the serotonin level will increase. While confirming the diagnosis, it's important to immediately stop giving the patient heparin and to start anticoagulation with a non-heparin anticoagulant, like argatroban, which is a thrombin inhibitor. If the patient has a thrombotic event, anticoagulation is continued for 3 to 6 months. If there was no thrombotic event, then anticoagulation continues until the platelet count normalizes. Alright, as a quick recap, heparin-induced thrombocytopenia, or HIT, is a condition where individuals on heparin therapy develop thrombocytopenia, or a low platelet count in the blood. HIT occurs as a result of an immune response, which ultimately causes the platelets to get activated and used up during the formation of abnormal clots. These clots can block veins and arteries, leading to life-threatening thrombotic events like deep vein thrombosis, pulmonary embolism, cerebral venous sinus thrombosis, and less commonly, limb gangrene, stroke, or myocardial infarction.
Von Willebrand disease is a bleeding disorder caused by a deficiency in the quantity or the quality of von Willebrand factor, a plasma glycoprotein that plays a key role in forming blood clots needed to stop bleeding. The disease was named after Erich Adolf von Willebrand, a Finnish physician who first described it in 1924. Von Willebrand factor is synthesized and stored in the endothelial cells and megakaryocytes. Its synthesis is regulated by the von Willebrand factor gene located on the short arm of chromosome 12. Alright, when there is a bleeding injury to a blood vessel, histamine and thrombin stimulate the local endothelial cells and megakaryocytes to release the von Willebrand factor into the bloodstream. After its release, it attaches to the exposed collagen fibers located in the wall of an injured blood vessel, where it serves as a glue-like substance that sticks to platelets receptors known as glycoprotein 1b, or simply GP1b. Within the bloodstream, more of von Willebrand factor starts to bind more platelets together into a kind of a mass, over which fibrin fibers deposit, forming a clot needed to plug the injured vessel and thus stop bleeding. In addition to binding platelets together, von Willebrand factor also binds and carries factor VIII. Factor VIII plays a major role in the blood clot formation process, and to work well, it is supposed to be bound to the von Willebrand factor because, in this case, it is protected from early degradation by protein C and S, which would remove it from the circulation before it does its job. Now, in von Willebrand disease, there isn't enough working von Willebrand factor to help with platelet adhesion and to bind and carry factor VIII, both of which makes it really hard to stop bleeding. The majority of von Willebrand disease cases are inherited, but it can also be acquired. In the inherited form, there is a mutation in the von Willebrand gene, and the gene gets passed from parents to children. Inherited von Willebrand disease is classified into 3 main types, type 1, 2, and 3. Von Willebrand disease type 1 is the most common, making up 75% of all cases. It is autosomal dominant, meaning that a mutation in only one allele results in insufficient or even defective production of von Willebrand factor. In von Willebrand disease type 2, the quantity of von Willebrand factor might be enough, but the problem becomes the quality. The type 2 is divided into 4 subtypes on its turn, which are type 2A, type 2B, type 2M, and type 2N. In both type 2A and type 2M, von Willebrand factor attaches well to the subendothelial collagen and factor VIII, but it is unable to properly bind the platelet together to form a plug needed to stopper a hole in a bleeding vessel. So in this case, it's like a fake glue that can't hold things up. In type 2B, von Willebrand factor binds platelets in the bloodstream. It is like the glue is too sticky, binding platelets everywhere, even when there is no injury. This causes large bundles of platelets to form in the bloodstream, which are taken out by the spleen and the liver, resulting in a low platelet count, another risk for bleeding. In type 2N, it binds both the subendothelial collagen and platelets well, but it poorly binds to factor VIII. So the factor VIII starts being degraded quickly, thus causing its levels in the bloodstream to fall, which also increases the risk for bleeding. The rarest, but also the most severe type of von Willebrand disease is type 3. It is an autosomal recessive disorder, meaning that both alleles must be defective to have symptoms. Because both alleles are affected, people with type 3 von Willebrand disease present with virtually no von Willebrand factor in their bloodstream, making the disease very severe. Also, since von Willebrand factor binds and transports factor VIII, people with von Willebrand disease type 3 typically present with a very severe factor VIII deficiency. Sometimes von Willebrand disease can be acquired, meaning having normal von Willebrand factor genes but yet present with the symptoms. This can be due to several physiologic disturbances that happen in other diseases, such as some autoimmune disorders like systemic lupus erythematosus, where the body produces antibodies against self-antigens, including von Willebrand factor, destroying it, and causes its levels in the bloodstream to drop. Other causes of acquired von Willebrand disease include some medications such as valproic acid and ciprofloxacin. These medications have been found to interfere with the synthesis of von Willebrand factor. All right, now people with von Willebrand disease present symptoms depending on the type of the disease. For example, those with inherited type 1 and 2A, B, and M are often asymptomatic or have mild mucocutaneous bleeding, like easy bruising, gum, and nosebleeds, and heavy menses sometimes. However, symptoms can become severe, especially in people taking anticoagulants or platelet anti-aggregant medications such as aspirin and other non-steroidal anti-inflammatory drugs or NSAIDs like celecoxib. Severe cases of bleeding typically present in people with type 3 and sometimes in people with type 2N. These people present with joint and muscle bleeding and gastrointestinal bleeding, but this one is rare. People with acquired von Willebrand disease typically present with new onset of bleeding on the background of some pathologic conditions, such as some autoimmune disorders, or on anticoagulants or platelet anti-aggregant medications. Diagnosis of von Willebrand disease starts with general tests like a platelet count, which is usually normal, except in von Willebrand disease type 2B, where it may be lower than normal. Other common tests include prothrombin time, or PT, and activated partial thromboplastin time, or just APTT. APTT is increased in affected people because it tests the intrinsic pathway, which includes factor VIII, which is reduced in von Willebrand disease. PT is usually normal, though, because it includes the extrinsic pathway that includes factors that work independently of von Willebrand factor. The next step involves assessing von Willebrand factor antigen, which measures the amount of von Willebrand factor present in the blood. It is followed by the measurement of its activity, which is done using ristocetin cofactor assays. When ristocetin is added to a plasma that contains normal working von Willebrand factor, ristocetin activates von Willebrand factor to bind to platelets, which adheres platelets together, resulting in visible coagulation. Okay, people with von Willebrand disease type 1 and type 2 that have bleeding episodes are treated with a vasopressin analog like DDAVP. DDAVP stimulates the endothelial cells and megakaryocytes to release von Willebrand factor. For people with von Willebrand disease type 3, DDAVP doesn't help because there's a complete deficiency of von Willebrand factor. So they are given intravenous von Willebrand factor concentrate, usually in combination with factor VIII. In some cases, when it is difficult to control bleeding, antifibrinolytic drugs such as tranexamic acid are used to help to delay dissolution of clots, thus sustaining clots for a little bit longer to prevent bleeding. All right, as a quick recap, in von Willebrand disease, there is a quantitative or qualitative deficiency in von Willebrand factor, which increases the risk of bleeding. Most cases of von Willebrand disease are inherited, even though people can acquire it later in life. Inherited von Willebrand disease is classified into three main types, which are type 1, type 2, and type 3. The type 1 and type 2 present with minor to moderate symptoms that include mucocutaneous and nosebleeding, and sometimes heavy menstrual periods. People with type 3 present with severe forms of bleeding that include bleeding in joints and muscles, rarely bleeding in the gut. The diagnosis of von Willebrand disease involves testing for von Willebrand factor antigen and ristocetin to test its activity. For treatment, people who present with minor bleeding are treated with desmopressin analogs, while those with severe bleeding receive exogenous von Willebrand factor and factor VIII concentrates.